live and ticking event. It's absolutely brilliant to have you with us this afternoon. You're in for a real treat. We've got some amazing speakers lined up to share their experiences and indeed some of their research with you, and we really look forward to hearing your questions throughout, so please do watch out for that in the sidebar and add your questions. A couple of things we find there we go. Please, if you could, put yourself on speaker view. That allows you to get the fullness of seeing our speakers in action. And also just to advise you as our viewers today that we will be recording the session to share with other people. So just sharing that with you. So we do have a wonderful lineup today. We've got a number of our speakers, so please let me introduce myself first. It's my privilege to be the Chief Exec of the British Heart Foundation. I'm Dr. Charmaine Griffiths, and I'm also joined by my colleague and our Associate Medical Director, Sonya, and also by one of our amazing BHF professors, who's also Professor of Congenital Heart Surgery and a Consultant of Cardiothoracic Surgery at the University of Bristol, Massimo Caputo. So welcome, Massimo. And also some great friends of the British Heart Foundation. We've got Nicola and John joining us to share their story, and we might even get a sneak preview of Calum, our heart hero, and their son. He might join us as well for a little bit today. So again, really welcome you to the session. It's brilliant to have you with us. We know from the last sessions we've run that you really enjoy these. We do too, and can't encourage you to ask questions enough. And please do use the question facility. So today we're gathered to have a really big and special discussion around congenital heart disease and congenital research. But before we dive in, I just want to take a couple of moments to thank you, our British Heart Foundation supporters, for everything you're doing for us at the moment. I don't need to tell you how unsettling the times are at the moment during this COVID-19 pandemic, and I hope this finds you and yours well. I know you will have heard much about the challenges facing the charity sector, and indeed our team are doing a brilliant job rising to the challenges that the BHF itself faces. This year alone, we've shared with you we anticipate our net income falling by around 50%, and consequently our investment in new research sadly falling from around £100 million to around £50 million. And it's support and the continued commitment of our BHF community that really are helping us get through this. I thought I might just call out a few beautiful examples from the last month or two of things people are doing to help us raise much needed funds. So the first was from a BHF supporter, Cynthia, who hosts an annual coffee morning every year in her home and has done for many years, but because of restrictions wasn't able to do what she normally does. But despite that disappointment, she baked away and offered to set it up anyway in a virtual and other sense, and raised a whopping £210, so bringing her total for the BHF to over £8,000. So our heartfelt thanks, Cynthia, and super glad you were able to continue in that way. And a couple of other amazing examples. We had 15-year-old Archie, and if you're on the call today, Archie, huge thank you. He walked the entire length of the Ridgeway National Trail, as whopping 87 miles, all in aid of the BHF, and so far he's doing that and has raised £1,800 for our research, so thank you, Archie. And if walking and baking wasn't enough to finish us off on our 3 examples, Rob and his friend Piers have paddled 60 miles from Inverness to Fort William in a 5-day coast-to-coast challenge and raised over £3,500 for the BHF in memory of Rob's mum, Jenny, who sadly died of a heart attack in December 2018. So I know many of you on the call today will be doing exceptional things to support our work, and I can only say a heartfelt thank you to you. It makes all the difference in powering research like that you'll hear about today. And lastly, if you were also a Tesco shopper and you rounded up your shopping to help donate to ourselves, Cancer Research UK and Diabetes UK, thank you. We know that we really hope and have everything crossed that amazing partnership with Tesco's will help raise vital funds for us at this time, so thank you for that. And indeed, if you joined our footy quiz earlier this month that was hosted by Chris Stark and had David Seaman and Glenn Hoddle on it, I hope you did better than my husband and I did, because we didn't score very highly, but we had great fun nonetheless, so thank you again for joining us. So before we start and focus on the amazing work of the BHF and our researchers and hear from the friends and families of the BHF, I was going to suggest we actually have a little poll to start us off on how much we all know about congenital heart disease. So we've got about a minute or so for this, and we've got 3 questions which I understand are going to pop up on your screens, so watch out for that. It's popped up on mine, I hope it has on yours too. So we're going to ask you 3 questions. The first couple you can see now are, how much do you feel you know about congenital heart disease? So everything from not much to very much, please answer. And also, how many people do you think are born with congenital heart disease each year? And you've got a range of options there, so please tell us what you think. And lastly, if you scroll down, there's a quick question here. This is a real brain teaser. Which pioneering research breakthrough in the field of congenital heart disease did Professor Samantha Yakub develop? So I can see people are pressing their buttons. So please take a couple of seconds to give us your answers, and all will be revealed during Sonya's talk in a moment. Lovely. If I get these wrong, Sonya, you can't, please don't call me out on them personally. She's like that, I can tell you. Good stuff. So I can see most people have had a response. So I'm going to suggest, whilst you perhaps continue to poll, I hand over to Sonya to get us started, and indeed encourage you to use the sidebar through the session, and look forward to sharing a bit more about the poll results with you in a moment. Over to you, Sonya. Sonya, so just checking you're off mute.
So I wasn't off mute, but just going to share a slide. Can you see a slide, everyone? Perfect, I'm getting some nods. So it's just partly to help me remember some of the things I'd like to talk to you about. So I'd like to begin a bit by just answering a simple question: what is congenital heart disease? So some of you polled that you don't know a lot about congenital heart disease. So when we say congenital heart disease, we mean it's a condition that someone is born with. So a heart condition or heart defect that you're born with. Actually, heart disease is the most common birth defect, and it's more common than some of you have realized, judging from the poll, which I kind of guessed. Just 0.8%, or nearly 1%, 1 in 100 children are born with congenital heart disease. So if we think of a school year as being 100 people, that's a person every year, potentially. It's quite a general term, and it covers many, many different congenital heart defects. So I don't want you to read this slide. It was to remind me to say that it doesn't mean just one thing. So any person that tells you they have congenital heart disease could have a myriad of completely different conditions, all of which need research, all of which need clinical care, all of which have many questions still to answer that I hope one day research will help with. So not only does it cover many different conditions that we label by the anatomy from simple to moderate to severe, each of those conditions also is a spectrum of different severity, and each person has a different severity of their disease at any one time. So certainly it's an umbrella term, and it means lots of different things. So if you and your family mentioned to the doctor that, oh, there was a grandparent and there was something about a hole in the heart, as a doctor, I don't usually know much about what that was in that era. A, because we may not have known when it was that grandparent or great uncle, and B, because hole in the heart can mean, as you can see, a million different things of very different severity. Perhaps it's nice to think about what has been achieved. And again, this slide isn't to read the graphic, but it's amazing to think that back in the 30s, 40s, 50s, 8 or 9 children out of 10 would have died of their congenital heart disease very, very early. And now, since the millennium, we can say that 9 out of 10 children will survive to adulthood and do very, very well, such that you have people like me. I'm the kind of cardiologist I am, is the cardiologist that looks after adults who are survivors of childhood and who were born with their heart defect. The very fact I exist as a specialist cardiologist is a testament to how amazing the story of congenital heart disease really is. I can't tell you everything about it, but I love that my specialty is so full of pioneers and heroes, and I really mean that. So if we think back to the very, very first interventions in cardiac surgery, it was for congenital heart disease. It was only in 1948 that the Blalock-Taussig-Thomas shunt was invented. What was that? Well, it was the first heart surgery, and it was for blue children who had tetralogy of Fallot, a particular condition I have a lot of interest in my own research. This was a time before they knew how to cross-match blood properly. Isn't that amazing? Truly, truly pioneering stuff. And the pioneering has been very, very much down to surgeons like Professor Caputo, who's going to tell you about what we're trying to pioneer now, but also people who've been very, very clever with other kinds of intervention. You may not know that the percutaneous, or the sort going through the leg or through your skin valve, so I didn't say that very well. Sometimes we can avoid open heart surgery, and we can put in a valve through a catheter procedure where you put a small sheath after local anesthetic, or even if you're asleep, into your leg, go into the heart and inflate a balloon on which is a valve, and can do a whole valve replacement through the leg. That's kind of amazing, and that's a very modern bit of pioneering. That was first described in 2000, so it's already 20 years ago, and that was prescribed for congenital heart disease and pioneered in congenital heart disease, not necessarily in aortic stenosis, where we hear about so-called TAVI, a very modern way of also treating aortic stenosis. So whilst this is a rare specialty and one where the challenge of research is enormous, I think it's also a specialty that has shown great imagination, great creativity, great science, and that has all led to great successes, such that now the expectation for a child born with heart disease can be very, very high for a long and healthy life, with difficulties and with more to do. So what about the BHF? Have we done anything to help in that? Well, of course. Back in 1961, there weren't all these medical and surgical advances when the BHF was born. And 60 years ago, most children will have died before they reach 16. So now, due to advances, including those funded by the BHF, more than 8 out of 10 children survive. And certainly this is no longer a disease only needing the expertise of children's doctors. It needs a whole multidisciplinary team of cardiologists, surgeons, pediatric cardiologists, adult cardiologists, even heart failure and transplant. Those pioneering successes changed the face of pediatric heart disease from what was once actually quite a palliative care type medical specialty to one in which these exciting and creative scientific pioneers found solutions that have saved lives. So how did we help? Hard work had to be done to understand the precise anatomy of the human heart and each of these myriad congenital heart defects. And much of that work globally has been contributed to by BHF professor Robert Anderson. He spent a career looking at their heart so that he could also explain to surgeons where the conduction tissue is, for example, where the electrical circuit of the heart is, so a surgeon can avoid it and avoid the patient needing a pacemaker. Without that kind of knowledge, we can't learn. So even me as a cardiologist, I learn regularly from human hearts, and to understand better how to image the heart, which is kind of like a living anatomy in our patients today. And certainly that kind of anatomical studies helped our surgeons better attempt surgery. And more recently, the electrical cardiologists who do ablation procedures where they pinpoint heat parts of the heart to cure arrhythmia also need very much to understand the very different conduction and electrical pathways in children and adults with congenital heart disease. As we learn more about the complexity of human development itself, it's perhaps wondrous to think that 99 out of 100 of us are all born with all our heart chambers and all our vessels correctly connected. There are so many things that could not happen as expected during the course of development. These days, many, many children are diagnosed in utero with their congenital heart disease, and we want to live in a world where that's 100% in places like the UK, where early diagnosis can mean you can understand what's going to happen for you and your family and your child and plan the care they need, including if that needs surgery. One particular congenital heart disease, which is called transposition of the great arteries, it's a condition where the two main outflow vessels of the heart are connected the wrong way around. I mention it because it's an area in which another BHF professor, Sir Magdi Yaqub, was a huge pioneer. Normally, blood returns to the two collecting chambers, or atria, in the heart, and is pumped to the two pumping chambers, the ventricles. And we have these two main outflow pipes of the heart to do that. One sends blue blood to the lungs and the other sends pink blood to the body. The blue blood needs to get to the lung to get oxygen and get pink again. But if the outflow tracts are connected the wrong way around, Blood without oxygen simply travels back to the body, and blood with oxygen simply travels back to the lungs, and in infancy you die without any intervention. So over the years, cardiologists and surgeons and interventionists have learned how to do things to help people. In early decades, that could have been making a hole in the collecting chambers of the heart to allow mixing of blood. Later on, an operation called a mustard operation, which has saved many lives, an operation done mainly in the 60s and in the 70s. But Professor Sir Magdi Yaqub worked out a better operation we could do to allow people to do better. If you have the older operation, you had more heart failure and problems. And the reason, and Professor Yaqub worked out how we could switch the outflow tracks back to the right place rather than do something second best. The reason we didn't just do that first time is surgeons will tell you that it took a lot of technical skill and new advance to learn how to re-implant the coronary arteries which sit on the aorta. And that technical skill was pioneered by Professor Yaqub and also a surgeon called Jatin in Brazil, who described this around the same time. So our patients, our living contemporary patients with congenital heart disease, reflect all these different eras of opportunity in surgery. As things got better and they grew older and there were more adults, Professor Jane Somerville came to the BHF and asked, could the BHF help with set up a patient association for those who needed support as they were living through adulthood and through new problems with congenital heart disease. And the BHF funded Jane too to set up a then called a grown-up congenital heart patient association. So it matters to us also to support our patients with the right information and to support them through learning about all these conditions. There's clearly more to do, and you're going to hear one fantastic example of how research is doing more for these children now. You can imagine some of these operations don't last a lifetime. So this icon here is from our latest medical guidelines, and it shows the road that a child born with congenital heart disease has to travel. We now my patients, we have a growing population of over 60-year-old patients. So this is no longer just a young disease, but the majority of patients are still under 60. But they have a long life ahead, and we need to learn better how to make investments at the right time. I didn't mean that financially, I meant it medically. Interventions for their rhythm, for their heart failure, for their valve function that will allow them to stay as well as you or I for as long as possible and have as near normal a life in terms of both quantity and quality as we can get. I'm cognizant that we repair the heart sometimes, we don't correct it. Some children and adults will need repeated surgeries over a lifetime, or repeated ablation procedures with the electrophysiologist, or repeated pacemaker device box changes, or repeated other therapies, new and old. So I think that our patients often describe themselves as fixed for now or mended for now rather than fixed or corrected. Certainly it's a lifelong care, and all patients should have access to doctors so that these new treatments that are being innovated all the time can be accessed by them. We can see great change. These are two BHF pictures, in fact. A young patient who's done very well and very proud of his surgical sternotomy scar. We're getting less and less invasive with our procedures. We'll be able to do more and more things that last longer and don't need repeat procedures. This is my patient on the right. Many of you may know him. I don't know if he's online today, Kieran, when he was really, really sick, because he had the older version of that operation I was describing to you. Had something called a mustard operation. And as he got into his 40s, his heart failed and he was struggling, and you don't have to be a doctor to think there are far too many pumps attached to him and tubes coming out of him. It's not a bad news story. I'm proud to tell you that Kieran is lucky. He got a transplant, another area of cardiology that Professor Magdi Yaqub was a pioneer in working out how we can do transplants for all people and how people can not reject their heart. And not only did he have the fortune to have a transplant, he participated in our research, my research at the time that was BHF funded and still does. And he has walked around the entire coast of the UK just to raise money so that we can do more for congenital heart disease in the future by doing good research that can save and improve lives. Not only save lives, so longevity is important, but our patients tell us that their quality of life is important. So all kinds of research that can help at every stage in the life journey. There's no better person to explain that to you than a family who has lived through the experience of having congenital heart disease and needing these kinds of treatments. So without delaying, I'd like to turn off this slide, which was simply to help me remember things to tell you. But, oh, sorry, that's just another picture in case. That was there to help me remember things I wanted to tell you, but mainly to introduce them, because I really believe that you're going to find a lot of interest in hearing a real world story. So may I turn to Nicola and John Morris, and we may meet their son briefly during the webinar.
Hi there. My name's, good afternoon, and I'd just like to say thank you very much for the opportunity for us to share Calum's story and to talk about the relationship that we've built up with Professor Caputo. So good afternoon. I'm Nicola and this is John, and we've got 3 children, Eleanor, Calum and Oliver. So as Sonya was saying, every day 13 babies in the UK are diagnosed with a congenital heart defect. That's over 4,000 babies every year, where the cause of the condition is mainly unknown. We, as a family, were completely unaware of congenital heart disease until Calum was born in 2006. At 1 day old, during Calum's routine baby check, a doctor detected a heart murmur or a different sound when he listened to Calum's heart with a stethoscope. An ultrasound scan confirmed a heart defect, and the words, "We are failing to find some major components of Calum's heart," will stick with us forever. As you can imagine, these words turned our lives upside down, and at that point we really didn't know what the implications were or if Calum would even survive. Calum was transferred to Bristol Children's Hospital and was diagnosed with a complex heart condition called truncus arteriosus. This is where the main arteries that come out of the heart had not formed properly. I remember being given a booklet from the British Heart Foundation on his condition, and this gave us the first glimmer of hope that this was a condition that was known about and they could maybe do something to help him. We were told that Calum would need major open heart surgery in the first few weeks of life, and this had significant risks. This was hugely scary, but we had no choice but to put our trust in Professor Massimo Caputo and the amazing cardiac team and hope that Calum had the strength to get through the surgery. Calum had his operation when he was 13 days old. I find it amazing to think that Massimo was operating on a heart the size of a walnut. Calum was in theatre for an incredibly long 6 hours. It was such a huge relief to see him in intensive care afterwards, but also really tough to see our tiny baby with an open chest and attached to lots of tubes and machines. Calum made a slow recovery from his surgery, spending 3 weeks in intensive care, but with a bit of time to recover and to regain some weight, Calum finally turned the corner and was able to be taken off the ventilator that was breathing for him. I remember this being a really emotional moment, as finally we could think about taking our baby boy home. We finally brought Calum home on the 17th of March, 6 weeks after he was born. We felt incredibly grateful, as before the British Heart Foundation was founded, the majority of babies with congenital heart conditions died before their first birthday. Today, thanks to advances in treatment and care, around 8 out of 10 babies with congenital heart disease survive and will grow up to be adults. When Calum had his surgery at 13 days old, he had to have an artificial tube inserted to act as part of his pulmonary artery, which takes blood from the heart to the lungs. Unfortunately, this tube does not grow with Calum, so this has meant he has had a number of further operations to replace this tube. He has had surgery at the ages of 4, 6, 11, and most recently in February last year at the age of 13. Having to have so many big heart operations is hugely stressful and traumatic for the whole family. Thankfully, we all have access to psychological support from the cardiac team, which helps us all through some of the tougher times. And we as a family are incredibly close and supportive of each other. Due to Calum's heart surgeries, Calum has missed lots of school and is unable to participate in lots of activities that his friends do. Despite this, Calum makes the most of every day and is incredibly positive. He loves supporting Bristol Bears rugby and is a keen gamer. He has faced so many challenges in his 14 years due to his heart condition, but he is incredibly happy, positive and determined. We certainly couldn't be prouder of him. Calum is incredibly proud of his special heart and has enjoyed fundraising and raising awareness of congenital heart disease for the British Heart Foundation. He has been part of big BHF campaigns, including Bag It, Beat It and Wear It, Beat It. He particularly enjoyed appearing on the Good Morning Britain sofa in 2015. He was also won British Heart Foundation Heart Hero Awards in 2016 and 2018. In 2017, ahead of Calum's 4th open heart surgery, he spoke to the British Heart Foundation about documenting his journey to his heart operation. Calum wanted people to know what it was like to have a special heart and have to go through heart surgery. This resulted in a series of small films being recorded on our phones and iPads, and these are available to view on the BHF YouTube channel. They definitely show the reality of having to have major heart surgery. Over the years, Calum has always had the same heart surgeon, Massimo, and he and we have built up a very special relationship with him. He has worked with us on a number of times to promote British Heart Foundation funded research that is being done at Bristol University. This work includes looking at growing heart tissue from stem cells, which would then grow when with the child, thus reducing the need for many repeat operations. This is hugely exciting research and could even benefit Calum at his stage of life. So we're really hopeful that this will come to fruition in the future. We already know Calum needs to have further surgery as he gets older, so we are hugely grateful to the British Heart Foundation and for the support of so many research projects that could ultimately benefit Calum in the future. Many thanks for listening to our story, and please do feel free to ask any questions in the Q&A section. Calum will just pop in and just say hello to everybody. You need to move.
Come on this side. Oh, fine.
Just say hi, Calum.
Hi. Hello.
So thank you for listening, and I'll hand over to Massimo to fill us in on the research.
Thank you very much, Nicola. And Calum and John, they've been such a big, important part of the BHF. I almost feel they should adopt me now, because we are now so we see each other so much for the BHF. But thank you, Sonya, because you made my job much easier, explaining so well the and so simply, such a complex subject. So I was just gonna talk about hopefully. Let's see, that doesn't work, I suppose. Can you see the video or not really? No, I'll try again. So stop sharing, and then I start sharing again. I say one participant can share at a time. Maybe no, I still can't see my. Okay, let's try again. This is something maybe whoever is leading the Zoom needs to.
Good point, Massimo. Charmaine here. I know that the team will be looking to. Oh, look.
Something happened.
Back to you.
Yeah. So, can you see it now? Yeah. let's see though if I can. Okay. So is this you are doing it or me?
I'm sharing
Give
the
us everyone
customer.
whilst we just get through a tech issue. So I think Leanne, you're clicking through. So Massimo,
Yes.
you could just say next slide when you're ready. That'd be great.
That's the only problem is the PDF. So I'm not sure it will show. Can I try and share it again? If let's see. Files.
And bear with us, everybody. I'm sure you've been on lots of family Zoom calls where you also have the same kind of thing. So give us a couple of minutes.
It may be something on your side that you have to allow me to share, or oh yeah, now I think maybe now. Let's see. Yeah, that's good. So I'm in control, or yes, right. So I will try and explain a little bit in simple words the research in congenital heart disease. Just to start with, oops. This is just a video I shot. This is one of my patients. This is an outpatient clinic. I'm explaining the operation to this young gentleman, the parents. You can see the mother shaking. This is one of the most difficult time for the family. And this was an easy interview because I operated on this gentleman who is the father a few months before of aortic valve replacement. So we already had a trust between each other. So you do need to explain the risk of the operation. At the same time, you're trying to recruit them in a study for research. And you can see here there are very few patients recruited into clinical trials in congenital heart disease. So this means that there is a big problem or difficulty in a way in recruiting. And it is, of course, understandable because of the stress of the situation. Together with this, there is a long patient journey. Sonya is a cardiologist, and she's the one who looks after the patient before and after, and we have a deep discussion with our cardiologist before we decide to intervene. Then there is all the intraoperative period, so the anesthetist, all the operating team, scrub nurses, perfusionist, again the anesthetist, and very also importantly the post-operative care. So you have to combine lots of effort in clinical effort in succeeding in the operation, but also conducting the research and talking to all these elements of the team. That's why we tend to use in the past research done in adults, and this is one of my patients 20 years ago, a coronary artery bypass graft. She's still alive and she still bakes me a cake every Christmas actually. But we cannot use the research we did in adults for young patients. And we know this because we have done quite lots of research looking at for example, this is a heart cell in a neonate. I think there is an helicopter coming. And then there is a heart cell in an adult. You can see the shape is completely different. The structure of the cells from a neonate into an adult is completely different. And what the cells, the heart cells are feeding with also varies during the development of the heart. So we cannot simply translate research in adult cardiac surgery into pediatric. And one of the elements in succeeding in a heart operation is during the operation. I will show you some surgical picture. I hope you don't mind. This is the picture of the heart. It's not very clear because you can see all these pipes attached to the heart. So when we do a heart operation, and this is a hole in the heart operation, we have to drain all the blood from the body, and then we have to stop the heart with this needle. So this is what we call cardiopulmonary bypass. Without this, we cannot perform any heart operation. At the same time, we have to stop the heart during the period we work inside the heart. And this is all damaging for the heart, for the brain, and for all the organs. And this is a nice graph showing how the longer you keep the heart stopped in minutes, the higher the damage measured by this specific marker here. So the perfusionists are a key fundamental part in success of heart surgery in children. And that's why we have conducted over the last probably 10, 20 years, two fundamental studies. One is called the OXIC study, and Sonya was talking about the blue babies. These are very high-risk group of babies who are used to live at very low oxygen levels compared to let's say, non-blue babies, so around 50, 60, 70%. When you put them on bypass, these babies, you hit them with a very high level of oxygen. And this causes what we call oxygen injury to the heart, to the brain, and to the kidneys. So we developed a technique called controlled oxygenation. As you can see here, this is the start of the operation here. And here you go on bypass. In these blue babies, we tend to keep the oxygen very low for the first 30 minutes and not hit them with the very high levels. If we do that, we have much less injury to the heart, as you can see here, and to the kidneys. So we're now routinely employing this technique for the blue babies. The other technique that we have changed recently is the temperature and how we stop the heart. And this is what we recruit in the thermic trials, more than 300 patients, and we completely changed our strategy from the early 90s, where we had to cool the body, to use ice lash around the organs to stop the heart. And now we completely change our strategy. We use warm cardiopulmonary bypass, we use blood cardioplegia instead of crystalloid. And all these has made a significant impact on the outcomes of our operations. And this is one of the arterial switch operation, a very complex operation Sonya was talking about. All over UK, we have now very good results in the follow-up. So these patients tend to survive and live very well. And this is, remember, the very operation that triggered in the 90s, the Bristol Inquiry. So the mortality were around 20–30% in those days. And this is a graph of the overall results in the UK. This is the mortality from 2000 to 2008, 2010. You can see how steadily, even in the early, in the late stages, coming down. And this is again from 2010 in 2018. So really fantastic results all over the UK. This is divided by centers. We all performing within are expected and or above expected. So a really truly fantastic story, I would say. And as Sonya was saying, this is unfortunately not the end of the story, because these babies are living longer. Sonya showed this graph. Now we have more than 90% survival in the adulthood. These are two of my patients who operated when they were children, and now they're having children themselves. So you can understand the problem. So the population we call adult population with congenital disease is growing and growing. And this is only 2000 now is much higher than the children with congenital disease that are steady. So this is a very epidemic problem in a way. And now we come to Calum's story. You have heard the story. The story is a very long story of resistance, of courage, of this young fellow who was operated. This is his heart. And there is a video here. Probably I won't show it to you, but it is when he was a neonate, and he had patches to close holes, a conduit with valves to connect the heart to the lungs. And this operation has been repeated now several times over the years. So what we are trying to do is to find better material to use, which is not a dead material as the ones we are currently use. These are all valves explanted after a few years from young adults, because they don't last long. They degenerate, they get clots in it, they get infected. This is also a TAVI valve Sonya was talking about. Also, this valve gets infected, so we don't have good material and material that can grow with this kit. So we have to put lots of effort in improving that. And this is what we do with tissue engineering. And we are lucky in a pediatric population because we have several sources of stem cells in the mother. During pregnancy, we can have fetal stem cells. We can have the umbilical cords and blood, we can harvest cells. And also when we do some palliative operation, we can harvest stem cells from these children. Then we seed the conduits or the graft that we want to use, and we then use them when they are very young, and hopefully it will grow. So it is a challenging problem, but it is very, very exciting. We tend to do prenatal diagnosis. So when you're pregnant these days, you can have quite an accurate diagnosis of the defect your child is going to be born with. And this is again an advantage because then we can use what we call the gifts from the parents, the placenta, the umbilical cord, and the umbilical cord blood. From all this tissue, we can harvest cells, and we can also take tissue to construct valve leaflets. So we've done all this work, and we have done all the cell culture, and then there is all the in vitro preparation, the seeding of the cells, the bioreactor, and the final products. And I'm just showing you one of the products we have created. This is a valve. This material is amnio. So the amnio is the sac of the placenta, which is very nice to create leaflets. As you can see here, we are cutting the right leaflets and then stitching to the material we're going to use to create the valve. And this is the final products with nice cells layered. This is a 3D reconstruction of the cells seeded. And then we do some experiment to show if there is a growth. And this is an experiment show that if you seed this graft with cell, there is a substantial growth from 1.7 to 2.1 centimeter compared to the control without cells. And also when we explant this, the histology is much better and very similar to the control. So we are now hoping to, this is how we test the valve in vitro model. This is one of the collaboration we have with the UCL and also with Palermo in Italy. And then the next stage, and all this work, I have to say, was heavily supported by BHF. He also won the Sir Jules Thorne Biomedical Award, and the Edellinder Foundation supported this. We are now in the process of applying to the MHRA, which is the regulatory agency that has to approve these products before we go clinical. But most importantly, we found a collaboration with the Royal Free in London, Professor Lodell. This is a fantastic facility which can upgrade our products into a product which we can use into the NHS and clinically. And we are applying for a safety study in 5 patients born with tetralogy of Fallot, like Elliot. This is one of my favorite patients. He keeps sending me pictures of him growing with his grumpy brothers, but he's already his 3rd operation. So we are really looking forward to these next steps. This is another quick way of doing tissue engineering without using cells, but using drugs. This is a specific drug called microRNA, which you can put in nanoparticles and then seed it into the leaflets you want to use. This is a gelatinous leaflets, and here in this picture, you see all the cells that this drug attracts, and this drug also is good for avoiding calcification, and this is the final product. It is another product we are trying to test very soon. We are talking about personalized medicine more and more, and we are lucky enough in Bristol to have developed a 3D printing service. So this is a 15-year-old boy with severe stenosis of his aortic valve, you can see. And now with this specific boy, we use a technique called Yosaki. So we cut a patch of his own pericardium, which is a sac that contain the heart, and we create 3 little leaflets that can replace the aortic valve. But the interesting bit is that we personalize this to him. So from his CT scan, from his X-ray, we can create a 3D model, which is his own aorta, and then I can use this to plan the operation, as you can see here, by looking at the model and then replacing exactly the leaflets and the shape and the dimension that I need. And this is an operation that we are very happy with. We are doing more and more of these patients without using those, as I say, nasty valves that I showed you before. So the 3D printing revolution is called. We have engaging in this revolution absolutely, because we feel it does help not only planning for the operation, and this is the unit that we developed in Bristol at Crick, thanks to the BHF and also to a local charity called Grand Appeal. And this is very important to plan for the operation, for new devices, as you can see here, or even for teaching, but also most importantly, to interact with the family and with the patients. I'm just going to show you this video if it works.
The Heart of the Matter is an exhibition that explores the medical and metaphorical heart, and each of the artwork tells a different story.
Throughout the exhibition, through sound, through visuals, we really see this idea of honoring the stories that are at the base of the heart of the matter.
There's the medical room, the room that explores technology, and then the final room which explores the narrative.
It's a beautiful reflection on the heart and on the human story that is behind all of this work.
So this is just to show how, this is all work done by Giovanni, who is my senior lecturer, supported by BHF, and Sonya, who is the artist, works in London, also in collaboration with Great Ormond Street, and how this work can join, in a way, art and medicine, but also is fundamental for the interaction with patients. How do we develop new techniques? Sonya was talking about the melody valves, so valves that are introduced in the body without having to open the heart, going on bypass and do all this invasiveness that we were talking before. But in most of these patients, this is a patient, an adult patient with tetralogy of Fallot, you have a huge heart. So we developed, I was lucky enough to spend 2 years in Chicago at Rush and working with the cardiologists. You can see here, this is a very rare picture, cardiologists and surgeons working together, Dr. Kenny, and we developed a technique by which we reduce the size of this heart by less invasive technique to make it much smaller. And then Damien could inject the valve, as you can see here. This is the melody valve injected without the need for opening the heart, and so a truly less invasive technique. This is the feedback from the American patient. As you can see, completely different narrative from we're used to, and I had to cover some of the words, but this is a feedback I always use here now to revalidate myself to the NHS. Heart lottery, what do we do also? We have to go abroad to help other countries, because there are thousands of children that are dying of congenital heart disease in less developing countries. And we've been lucky enough, like lots of other surgeons in UK and around the world, to establish other units. This is a unit in Trinidad, which we established, is now up and running, and we go now there, but it is now independent. And this is another story, unfortunately sad, because the war completely collapsed the building. We established this unit in Homs, and again, we were going there. It was great also for our staff, because we were doing things that like early extubation of the patient or fast track that helps also our NHS patients. But you can see the big effort, the wonderful time we had, and the lack of facilities, huge beds for tiny babies. As I said, unfortunately, this all stopped because of the war. Now, what is the future? Is definitely the future is to link all the 12 centers we have in UK and Ireland. We are doing this together with the BHF and NHR. We have a very strong social medicine department with Professor Laurel and George Davis Smith, and we are trying to run now longitudinal study. And our aim and dream is to recruit every child coming to cardiac surgery into a longitudinal study. And this is also goes well with the initiative that the BHF, you probably know, has founded heavily the BHF Data Science Center in Edinburgh. And hopefully this will also put congenital heart disease at the center of their strategy by linking all the different data sets that we have in the UK, which are now a bit disjoint and not talking to each other. And finally, I want to just tell you a nice story. It's a Finlay story. This is a baby born with the gain transposition who had a very, very difficult time, to say the least. We almost gave up on him. He was connected with the ECMO, with a machine to support the heart. There was no improvement after weeks and weeks in the hospital. It was during the COVID time, so we couldn't even ask for a transplant. There were no organs. So thanks to the research I was doing with the Royal Free and Mark Lodell, I convinced the Trust on Compassionate Base to try regenerative medicine with him. So we use allogenic stem cells. We injected in the heart. And as you can see here, he's made a very nice recovery. I was, as I said, surprised like anybody else, but this guy never gave up. The mom, Melissa, was also so strong. And to be honest, we were so happy and almost emotionally happy to see this recovery. I talked to Melissa today, and she confirmed he's doing very, very well. So this is just an example of how research can connect people together and bring ideas that can truly save and change lives. And with this, I would just like to finish with thanks to all the patients and parents that send me picture. These all the patients. One of the things I like the most is to receive this picture and to see them growing. There are lots of them. Sonya, I'm sure, has got a collection of them. This is another patient after Ross operation. This is one of the most wonderful things, presents we can receive from our patients. And so, of course, thanks to the BHF for his great support.
Oh, Massimo, thank you so much for sharing both your amazing research, but also the stories of so many of the lives of patients and children that your work has touched. So I know everyone on this call will join me in thanking Prof. Massimo Caputo for that amazing presentation. I can see a few people clapping, wonderful. And also I know you'll join me in thanking Nicola and John for sharing their story so honestly and courageously with us, and also to get the chance to give us to give Calum a wave. I thought that was lovely. So thank you as well. And Sonya, for your overview of Congen research. I know that about only 1 in 10 of us felt we knew something about congenital enough about congenital heart disease at the start of this. And I suspect if we did that question again, we feel like we could answer a little bit more confidently. Now, I know that you, rightly, this session was to hear from Massimo, Nicola, John, and from Sonya. And we have had quite a few questions in advance, and you've got our commitment that we'll respond individually to anything we don't get time to cover today, so there's no rush to cover things. But I am going to ask Kelly, actually, if there's perhaps 1 or 2 questions that we could squeeze in before we wrap up. So over to you, Kelly, who's behind the scenes looking at all the questions coming in. Over to you.
Yes, of course, thank you. So the first question is for Sonya. Are adults with congenital heart disease treated differently to young children with congenital heart disease? Sonya.
Okay, so there are kind of different problems that we might expect to see in adults. Some people are really, really well. So it's quite important to say that, because when we do talk to people, we might pick a story of someone who's had lots of need for operations and surgery. Some people remain very, very well, go to university, they're working, they're well. But one of the things that I find most challenging is identifying amongst those particular people who have no symptoms, no breathlessness, no chest pain, no obvious heart rhythm disturbances, the ones that might be at risk of a sudden life-threatening arrhythmia or a sudden death. And that's something that is really very much an adult problem. That's kind of a different topic from the things we consider in children. It's only something that starts to happen once your heart gets older. and in a later frame. So one of the pieces of research that BHF funded me to do and other colleagues to do has been very much on trying to help better decide who might need prevention of such an event. So we all watch TV and we see resuscitation, and it always works on TV. And if it happens in a hospital, obviously somebody can come to you very quickly. But what if the very first time you have a life-threatening arrhythmia, you're out and about and you're far away from anyone to even witness it, or who could even call for help? And that exercises my brain, and my challenge a lot with my patients is trying to figure out as best I can when to advise that we need to do something in advance of it. And that could be having a small defibrillator under your clavicle that just looks like the size of a matchbox that could recognize the ECG inside your heart if this happened and give you a shock in the community without waiting for someone to be able to get to you in time. Obviously, all the other things BHF do, like having a nation of lifesavers, working in collaboration with others so that you could find your nearest defibrillator and help another person in the street, will all help. But there is an underlying difference in some of the patients I look after with congenital heart disease, partly because they have surgical scar, and the combination of surgical scar and later pressure and the volume overload of the heart due to how the particular anatomy and physiology of that particular person progresses can be the ingredients to have one of these arrhythmias. The other thing that I worry about a lot in adults is having heart failure too young. So we're all different ages on this call, and young may mean different things in congenital heart disease to different people, but I do have patients in their 70s, even 80s, and even people diagnosed for the first time with congenital heart disease in adulthood. But one of the things that we're always looking to do is to behave a bit like spooks, and it's the best way I can describe it. We don't want to just wait till people are in extremis and breathless and can't move up a flight of stairs. We're kind of looking often with imaging to see whose heart is changing and whose heart might need more treatment before they even have symptoms. Because we learned the hard way that if you just wait for people to get symptomatic, it's quite late in the disease progress. So another kind of difference, and well, maybe not a difference, it's true for all patients of all ages, is that we screen, we do a lot of surveillance on the medical side of the follow-up. So we have had huge advantages and advances across cardiology in imaging, in echocardiography. The echoes that people take today are even different from the ones when I was training. They're so much better and so much more detailed. We can look at the heart in 3 dimensions. I use MRI a lot, and there was an MRI picture or two in Professor Caputo's talk as a way to image the heart, and that has become routine in the UK, and it's absolutely vital in congenital heart disease, especially in adults. So the spooks bit where we're sort of surveying and spying to look for if your heart's changing before you notice happens from childhood, but some of the ways we look become different in adulthood. So we often will do exercise tests and MRI scans as well, because we can't see the heart enough with just the echo. I could try and give more examples, but it will only reflect how enthusiastic I am about this subject and how much I believe we can do and need to do and need funding to do. It's an area of undernourishment, I would say.
That's great. Thank you, Sonya. I'm afraid we haven't got any more time for any more questions, so I'll hand back to Charmaine to close the event. Thank you.
Lovely, thank you, Kelly, and thank you, Sonya. And I know, because I could see everybody's faces on the Zoom call and their virtual applause, I know you'll join me again in thanking both Massimo and Sonya and Nicola and John for just sharing both their amazing research, their personal experiences, and some of their thinking with us today. We really hope you've enjoyed this session, this live and ticking event. We love them because we love to hear what's important to you in questions and also have the time to kind of reflect together. We're incredibly proud to be funding Massimo as a British Heart Foundation, and to have many researchers like him supporting families just like Nicola and John's across the country today and every day. But we couldn't do what we do without you as our British Heart Foundation supporters. So my heartfelt thanks to each of you for your support for what we do. It just really helps us make a difference in our work to tackle heart and circulatory diseases. So thank you. So I hope also you'll join us at the next one of these. We've got the next one on the 21st of October. So please do join us then and watch out for that, and tell your friends and family to join us too. And if you haven't signed up already to hear more about them, please visit bhf.org.uk on our website, massimo.org/public events, and you can sign yourself up there. And lastly, as a bit of an exclusive, sharing with you that in the follow-up email that you'll get, and in the chatbox link here, you'll get an exclusive virtual tour of Massimo's operating theatre. So Massimo, I don't know how you've managed that technically, but we're offering that to you to get behind the scenes glimpse. So please do enjoy that and have a look around and get a bit more feel for the environment the work happens in. But otherwise, thank you enormously for joining us, and take care.